and our event recording has just begun. So I'm going to give it about 30 more seconds, and then we will go ahead and begin. Good afternoon. My name is Dr. Alyssa Ward, and I am the Behavioral Health Clinical Director at Virginia's Department of Medical Assistant Services. It is my pleasure to welcome you here to this WebEx meeting, where today we will be providing an update on the enhancement of Medicaid behavioral health services. I am joined today by a number of our colleagues. I want to begin today with a basic orientation to the call, and then want to hand the microphone over to Karen Kimsey, the director of our agency, who would like to say a few words of welcome this morning. Just a couple housekeeping notes before we begin. Because of the size of the call, we're up to 141 participants. We will note that you are all muted at this time. The question and answer function is available, though we will not be live answering questions during the presentation, as we will be practicing a mindfulness to the delivery of the content and not multitasking. When we reach the end of the presentation, we will determine how many and which of the questions would be appropriate for us to try to answer, but we do want to note that we of course welcome your questions and comments, and we do maintain our email address, enhancedbh, as in behavioral health, at dmas.virginia.gov, where you can always send those questions, and we always respond in a timely manner. So we will get started with the PowerPoint presentation, and then this will be sent out to our stakeholder list following the call, and also posted to our DMAS website on our behavioral health page. We are going to hand the mic over at this time to Director Kimsey for a welcome. Thank you, Director Kimsey, for being with us.
Thank you, Dr. Ward. I'm very excited to be here, and good afternoon, everyone, and happy Monday to you. And I just want to welcome you. It's such a large number of people, and it just goes to the excitement and interest and where we're moving in terms of enhancing the behavioral health services we cover for our Medicaid beneficiaries. I just want to welcome you here today, and just to reassert to you all that you have our firm commitment that the advancement of these changes are one of our top priorities for our agency. And in the middle of all of the issues that we're dealing with related to COVID, and I know that some of the changes related to this have been put on pause, like many other priorities in the Commonwealth while we deal with COVID. We are very hopeful, are still in the teams at DMAS, as well as the Department of Behavioral Health and Developmental Services, are working very hard to continue advancing in our planning stages. So when we do receive the green light for funding through the legislature and with our administration, that we're able to hit the ground running with you all. And we are very pleased to be here with you. Look forward to hearing your questions, and just thank you for participating. And I look forward to being a part of this with you all.
Thank you, Director Kimsey. And I also want to acknowledge Laura Reed, our behavioral health manager, who is our host today here for this event and who is supporting us with the slides. Thank you, Laura, and you can advance to the next slide. I will be sharing this presentation today with my esteemed colleague, Dr. Alexis Aplaska, the Chief Clinical Officer at DBHDS. And we will be taking turns sharing this content today and handing the mic back and forth as you are accustomed to us doing in our prior presentations on the topic. I will kick off the discussion today, so Laura, you can move us to the next slide. This overview should be familiar to all of you who have been so invested in this project from its inception. But as a reminder, and should we have any new voices at the table today, just wanted to remind you that the vision for the enhancement of the behavioral health services for Virginia is really to implement a fully integrated spectrum of services that cover a continuum of care across all of kind of the necessary levels of care in a high functioning system. That comprehensive system uh, aims to focus on access to services that are of high quality, that are based on what we know works from the evidence and from science, and really driving towards least restrictive environment for our members, and looking closely at the prevention and early intervention literature to drive the system. Another area of focus is becoming trauma-informed and assuring that we use a trauma-informed lens as we're examining both the services that we're implementing, but also the impact of service delivery on the workforce, particularly during this time of COVID that is so relevant. There are so many concerns for the trauma that everyone has most recently experienced, but for many of our members have experienced historical and race-based trauma. And so all of those perspectives are really meant to be integrated into this implementation plan as we move forward. And then finally, cost effectiveness. So we have spoken throughout, and we know that our stakeholders appreciate that public funding is limited for mental health. We hope that that changes over time, and that there is, as there has been, increasing attention and awareness for the need for the expansion of services for mental health needs, and as those needs are reflected in our current state of emergency, becomes all the more clear. But given the limitation of those funds, we want to assure that we invest that funding in things that are going to be most effective for our members and really allows us to serve them best with the public funds with which we are entrusted. Next slide. There are a number of different other excellent projects that have been going on across the state and across HHS and beyond, HHR and beyond, over the course of the last few years. And Enhancement has always sought to be, as I've always said, the big hug around all of those other efforts, and to assure that kind of Medicaid stays in step with that good work that has come before us and is walking alongside us. One of those major projects has been the Family First Prevention Services Act. And that work is, being lifted primarily by the Department of Social Services, the Office of Children's Services, and the very large implementation stakeholder group that goes with that many of you have been a part of. The goal there, as we want to acknowledge that some of their monies have also been frozen through the unallotment process, is we have also stayed in very close touch with the implementers of that process to assure that, again, we remain aligned with them around ways that we can work together to be effective in workforce development and implementation of evidence-based programs that really are serving the same and overlapping workforces and pools of people who participate in service. We've also taken many lessons from the juvenile justice transformation in Virginia, which really gave us some good preliminary data on the rollout of evidence-based practices, particularly in community-based settings, and more recently, efforts to increase services in rural settings where they haven't been available before. And finally, the continued work of the Governor's Children's Cabinet on Trauma-Informed Care. We remain active with that cabinet in assuring that the priorities for the administration around trauma-informed care and mental health needs of children are reflected in the enhancement proposal as it evolves. You'll notice on this wheel of alignment visual, you can see a number of other important projects, including STEP Virginia, and we're going to hear in a moment on the next slide from Dr. Plaska as a reminder about kind of the alignment between these two core initiatives. Next slide. Dr. Plaska, you can take it away on the next slide.
Hi, good afternoon, everyone. So this slide is also not new, hopefully, to most people on this call, and this really talks about how behavioral health enhancement really builds upon STEP Virginia as one of the foundational components for transformation of our behavioral health system. And so STEP Virginia building more, increasing access, quality, consistency, and accountability across Virginia's public behavioral health system, which we all view as essential and critical safety net providers in our mental health system. And then where behavioral health enhancement is really intended to build upon is the implementation of high quality, high intensity services, investment in the workforce development, including provision of adequate reimbursement to recruit and incentivize providers to serve where is most needed, and then transition funding to those outpatient services, integrated services in primary care, schools, and other intensive community-based and clinic support. So in the General Assembly session, what was proposed was the implementation of 6 services that demonstrate high impact and value. One of the most critical alignments that we have are those related to STEP Virginia, as STEP Virginia has already been in flight now for several years, and creating sustainability around the services that are part of STEP Virginia. And so those were those 6 critical service priorities came from, along with addressing where people are right now. And we know that a lot of them are really being driven into high acuity services like inpatient care and crisis. And so those 6 services also aim to meet people to be able to step them down from those settings as well. All right, next slide. So these are the top priorities at this time. So those 6 high quality, high intensity, and evidence-based services are ones that are currently existing and licensed in Virginia, but are not covered by Medicaid, or the service is not adequately funded through Medicaid. So for example, the 6 that are mentioned here is partial hospitalization, intensive outpatient programs, programs of assertive community treatment, multisystemic therapy, functional family therapy, and comprehensive crisis services. So there are partial hospitalizations and intensive outpatient programs that DBHDS licenses, but for mental health in the Medicaid space, those services aren't available. With program of assertive community treatment, this is also available in Virginia, but not really adequately funded through the Medicaid space. So most of those programs are through general fund dollars. And when that happens, there is a limit to how much expansion can happen. So it's not necessarily available at all 40 CSDs, but obviously very critical in the high quality evidence-based program. And the same thing with multisystemic therapy, which is available in Virginia, but not adequately funded through Medicaid for the type of service it is. It's a highly intensive, family-based treatment that is team-based. The workers, the MST workers, are available 24/7, and that rate is just not there yet for Medicaid. And then the same thing with functional family therapy, which is another family-based high-intensity service. In comprehensive crisis, Multiple components are funded through Medicaid, but this is also a key component not only of STEP Virginia, but the DOJ settlement agreement that our Commonwealth is under for the population for developmental services. And so there was an opportunity there to align and really provide diversion to and diversion from state psychiatric hospital admission, which we have heard time and time again is at over census, most times as a year. These also demonstrate a lot of cost efficiency and value in other states. So again, being mindful that the resources are limited in the Commonwealth, just like they are in other states, and states that have these services that are robust and adequately funded from Medicaid really divert from the costs related to high acuity inpatient services. Next slide.
So I'm going to speak to this slide, and then Dr. Plaska will kind of join in on the next one. One thing that we wanted to note is that, you know, across the period of the state of emergency, we have kept our eye on what has been happening to the services that are those that we are hoping to lift with an enhancement. And we've wanted to understand, you know, both what is happening broadly within the behavioral health services that do currently exist for Medicaid reimbursement, but also to those that we are seeking to bring into the benefit, and just to understand what it's looking like out there. And so in discussion with the developers of some of these services, as well as boots on the ground and hearing from providers who are doing the service, what we've been hearing has been relatively good news, given how difficult we know this is for everyone right now. We have heard that multisystemic therapy and functional family therapy have been able to shift to a combination of telehealth and face-to-face interventions with continued positive outcomes. We've even heard from the developer that the positive outcomes they have seen have helped them to kind of rethink about the standards they've had around requirement for the proportion of face-to-face intervention, because things have been going so well over telehealth. So that's really encouraging to hear. The number of teams for these have continued to grow in Virginia. They have continued to train and to bring on new teams, which is a really good piece of news in terms of the potential to continue to grow should we be reallotted an enhancement despite COVID or any of the limitations of the state of emergency. And we are also seeing that families are remaining engaged in treatment despite the shift in the way that they're participating in care. So that is all really good news. We also have heard very good news about the incredibly dedicated PAC teams that are out there for the most part at our community services boards. And so if we have any folks from the PAC teams, I know we must have some out of this 168 people on the call right now. I'm giving you jazz hands right now. I almost want to go on video just so you can see those jazz hands, because we have heard about how hard you are working and how dedicated you are to the members that you serve. We have heard that those programs are continuing to deliver services and have not seen lower members in attendance. We've seen from the billing that we do see on Medicaid of this service, we've seen relative stability in at least the billing for the service. And we have heard that some programs have even experienced growth, which is not necessarily surprising given what we know about increased needs for services during this time. And there has been an addition of a PACT program into the Virginia implementation. So these practices appear to be resilient and sustainable, and to have really strong, committed workforces. And so that speaks to a hopeful future hopefully through enhancement. Next slide, I'll have Dr. Plaska speak a bit to PHP and crisis.
Can you hear me?
Yeah, I can hear you.
Okay. So how are these services functioning during COVID? As Dr. Ford had mentioned, there is some stability and they are proving to be sustainable. So partial hospitalization, intensive outpatient programs, our staff is licensed professionals able to deliver professional services. They've been in a combination of telehealth and face-to-face treatment. So the existing programs that we currently have in our system have been reporting very kind of innovative and creative ways to continue providing the support that they need for the patients and people that they serve. The referrals have increased to outpatient mental health providers due to individuals choosing the least restrictive care. And so because a lot of the face-to-face services and group-based types of programs have been suspended for some period of time to adhere to the public health guidance and safety, there is now what we've seen a shift to those outpatient sort of individualized care. And then the comprehensive crisis services continue to need to be needed to reduce unnecessary hospitalization. And these have been performed through telehealth when clinically appropriate. So a lot of telehealth providers do crisis evaluations, including some of our CSB partners who've been very innovative and been able to also provide some CDO evaluations through telehealth and have shifted into that ability to do so in very rapid fashion, particularly, again, related to COVID and wanting to limit face-to-face, limit the need for PPE, avoid emergency room visits, and all of those sort of downstream effects related to COVID. The comprehensive crisis services, just going to loop back to that. So we did experience a bit of a kind of pause in our state psychiatric admissions when the kind of strictest shelter-in-place order was in place at the start of the pandemic. But now that we are in phase 3 of Forward Virginia, we are again now in a critical census capacity. And so those crisis services, again, are just critical no matter what the background is related to COVID.
Next slide.
Want to talk about this one, Alyssa?
I can talk about this one. So we wanted to kind of remind folks and then bring you up to date just about the governor's budget and what was originally allotted for behavioral health enhancement. So before COVID, the cost for the services was split across the biennium with kind of staggered implementation dates, with multisystemic therapy and functional family therapy and PACT going first. And the start date was to be January 2021, with a follow-up of July of that year for comprehensive crisis, partial hospitalization, and intensive outpatient. And you can see the costs were largely in the second half of the biennium. And next slide. There's your grumpy coronavirus face. So these funds were all frozen. So, you know, in the unallotment, that doesn't mean that they are gone. It just means that they are frozen in place as the General Assembly determines its priorities. And as there was reforecasting and I think continued reforecasting and determination of kind of what funding is available and what funding will be prioritized. So next slide. Dr. Oplaska.
Sure. So this is the what was in the governor's budget and came out of the GA related to the funding through DBHDS. So there was a little over $1 million in FY21 for training in preparation of behavioral health enhancement, as well as in FY2022 of 1.2 million. And then also the alignment, the Emergency Regulatory Authority for the alignment of the licensing with the Medicaid Behavioral Health Services. So, not sure if I have the same grumpy coronavirus face, but
he is ever present, though.
Yes, he's ever present. And so, if you go back one slide again, so that if you can imagine the face also there is unallotted funds for the workforce preparation, the 1 million and the 1.2 million there. But we are proceeding forward with the alignment of the DBHDS licensing related to behavioral health, Medicaid behavioral health services. So that alignment is really intended to, since we don't kind of know when and how those funds will become allotted, we definitely don't want licensing to be a barrier to being able to implement them. So that is still moving forward.
Now we can move to the next slide. So this is our former kind of implementation overview slide that hopefully most of you are familiar with. And this is where in the past we've kind of highlighted the major areas of implementation and where we would lift them. So, you know, coming towards the end of the GA, if authority was granted to proceed, we would have planned, you know, in a non-COVID world to have reconvened our regular stakeholder work groups for installation planning, installation being, you know, one of the preliminary steps in an implementation model. And that installation planning would have involved consideration of all the system changes, preparation and submission of our state plan amendment, regulation and manual updates, statewide workforce training, and then internally at DMAS and DBHDS, consideration of the metrics and dashboards that would be helpful with stakeholder input to report out on implementation progress and outcomes. And this would all be leading to an engagement with CMS on a potential 1115 serious mental illness waiver application, which we know there has been great appetite for. However, we really have not been eligible for because that waiver requires that there are evidence-based practices in place in community-based services, which we really are not able to demonstrate before enhancement is initiated. And so the plan would be, you know, kind of once we are moving and have authority to move and are making clear steps to move towards that eligibility, that then we would engage CMS to apply for that waiver, which would basically allow for us to cover expanded services such as residential group home for those with serious mental illness. Now comes the grumpy corona face. Next slide is going to show up here in the middle, and then the next slide. So we have a revised plan for how we would implement should we be re-allotted and able to move forward with this priority. Also, we are evolving, right? We have not stopped working. We have not barely stopped to take a breath. We have continued to do everything that we can to keep this process alive and to assure that should we be re-allotted, we would be ready to move immediately and ready to make the changes that the system needs right away. And so we've also, you know, been watching and participating in the conversations and the changes that are going on in kind of our larger system and culture. And so we are aware, you know, that beyond our initially proposed stakeholder work groups, that we feel there are additional perspectives that are needed as we move through this process. And one of those is a racial equity lens that we really want to work with stakeholders to develop an initial racial equity work group that we would take nominations for, much like how we took nominations through the associations for the service-specific work groups, of folk to sit on that work group to prioritize, you know, looking at the implementation plan and looking at the way services are laying out to assure that, you know, that we identify vulnerabilities in terms of equity, that we seek to address racial inequities and health disparities as they have existed through this process, and see that what we can do towards those values of addressing racial equity through behavioral health enhancement. So we also have a General Assembly mandated behavioral health enhancement advisory work group that is kind of a specific mandate, and we are actually starting that meeting tomorrow. So that work group is beginning, just to assure that we have engaged them and are prepared for the mandated report and able to respond to kind of the concerns that group has about the implementation. So other things that we have continued to work on is, for example, we have started working on draft state plan amendments and for all of the services, because that's a whole process, and it's something that we were able to begin to prep and work on without having to submit it properly yet. Likewise, thinking about how that would translate to manuals. We've always, throughout this process, talked with stakeholders about our desire to really rewrite the manuals so that they are more reader friendly and more driven by the provider experience, and they're easier kind of for everyone to reference to. So we have been looking at that process, and then, as noted in the MST-FFT slide, really talking a lot with our different partners about what workforce training has looked like during COVID to assure that we have ideas should we be able to move forward and we're still under some level of social distancing restriction, to think about how we could move forward training. Likewise, we've continued at DMAS to work really diligently on the development of capacity for metrics and dashboards. So there have been a couple different major initiatives, and I'd like to credit Dr. Cleo Booker, who is here on the call today, with tremendous efforts that she has put in towards that end. We have worked on an internal template. Oh, good. Thank you, Laura. Laura's reading my mind here. We have created some templates for service-specific dashboards, including analysis of utilization, regionality, demographics, so that this is not something that we have had this way in the past, and it's due to some new technology that is available to us that is just coming online. And so we have worked to develop those templates and hope that in the future we can have those be more public facing for new services and existing services, so we can kind of be able to talk together live about how the system is changing as the services are enhanced. We've also been working through a serious mental illness innovation accelerator program through CMS to develop a dashboard specific to the serious mental illness population, to look kind of across agencies, across data sources, about what the needs are of folks who participate in services related to their care. And that will be really helpful for us in preparation for the 1115 waiver and in evaluation of that waiver, should we be able to apply for it. So we have really been pushing all of these efforts ahead, including, stepping back real quick, we've been looking at and developing medical necessity criteria for all of these services, making sure they're very crystal clear and much more specific than we've ever had in the past, which will really help everyone and behoove everyone involved in the care. We've had a lot of great conversations with our partners at DBHDS and DSS and OCS about training and how we could continue to move training forward. And we have continued to meet bi-weekly with all of the behavioral health associations during COVID to understand kind of where the current system has been able to be resilient and where it has struggled. We've also worked kind of on the back end towards the development of an evidence-based practice center that would be a cross-agency center and university partnership, and have continued to push forward with those efforts, as we think it would benefit all of the implementations along that wheel that we presented at the beginning. And just preparing ourselves to be ready to go. Next slide. Dr. Plaska, you want to wrap us up here?
Can you hear me now?
She's here. Yes, we can hear you.
I really got to work on this double muting thing here on the computer and phone. So, so we are also doing a lot of work at DBHDS. We have active meetings with our providers as well in terms of helping to support them, providing guidance along the way, ensuring that our communication between our DMAS partners and ourselves is discussed. It remains an important priority for our agency. We know that it is as important now as it was before, and so please let us know sort of what questions that you have, kind of where things continue to be kind of up in the air for everybody, and we'll be happy to coordinate again between the two agencies to answer those to the best of our abilities. So appreciate everybody jumping on and participating.
I want to just echo my thanks and appreciation for everyone's continued partnership through this process and your participation today and your participation in our provider calls each week. And I do also want to take this opportunity as we end today to make an important announcement. And I'm going to pass the mic over to Dr. Cleopatra Booker, our Senior Advisor in Behavioral Health, to make that announcement.
Hello, everyone. Can you hear me?
Yes, I can hear you.
Awesome. I know that many of you have been in communication with me at least over the last few months, and some of you have been in communication with me in my various roles in Virginia over the last few years. The last few months, I've been the Behavioral Health Advisor for DMAS, supporting many efforts, including behavioral health enhancement. At this time, I would like to inform you that August 10th, 2020 will be my last day at Department of Medical Assistance Services. I've accepted an executive position within a company, allowing me to transform and lead the innovation of behavioral health care across the United States in over 30 states and potentially reach over 6 million lives. I'm excited about my next steps, but also will absolutely miss this group and the commitment and passion that you all have. I'm going to miss my state partners and, of course, the dedicated and committed team here at DMAS that I've had the honor and absolute privilege of serving with. Although my time here at DMAS has not been long, my time working across the Virginia systems of care has been. During my time at DMAS, it's been such a rewarding experience to watch and contribute to so many historical moments in such a short period of time, such as behavioral health enhancement, responding to COVID-19, and now planning how telehealth will remain an expanded valuable option for delivering behavioral health services across Virginia. It's been a pleasure working with each and every one of you, and I look forward to continued work that will be done in Virginia and across the nation to enhance, transform, and integrate behavioral health care. If you would like to remain in touch with me, you can connect with me on LinkedIn. And I want to say thank you for contributing to my wonderful experience that I've had at DMAS, and please keep up the momentum to enhance behavioral health services.
Thank you, Dr. Booker. We really appreciate you sharing your news with the group today, and we appreciate all of your contributions to the Behavioral Health Enhancement Project and to the COVID response, which has been so tremendous over the last 4 months. So you will be very missed.
Thank you.
I'm seeing just a few questions in the Q&A. And so I want to note that.
I will read them off for you.
Sure.
Pasta, yep. Okay, so one of the unanswered questions that we have is there an expiration date on telehealth for ABA services at this time?
So it sounds like this is a question that is really about the provider flexibilities afforded through some of our federal and state waivers for the COVID time period. Um, rather than enhancement. What we can tell you at this time is that all of our flexibilities, including telehealth for ABA, have been extended through the end of the state of emergency. And at this time, we don't, as you may be familiar, in terms of Executive Order 51 in the state of Virginia, we don't have an end date at this point, but those, some of the kind of telehealth allowances, for example, use of non-HIPAA uh, compliant platforms or audio allowance, those are afforded to us through the federal waiver through HHS. And so it will depend. We have heard that those are going to be extended into October, but I don't believe, I was on vacation last week for the first time. I don't believe that we've received the formal memo down from the federal government about that, but there was a tweet from the federal government about it being forthcoming. So we don't have confirmation yet, but we do expect that those telehealth flexibilities are going to extend for quite a while now. And then internally, we are looking at and examining our long-term telehealth policies.
This is Karen. Dr. Ward, you are so correct about that. We anticipate that formal announcement, but the tweet is all everybody nationally is waiting using it.
And apparently this is how we learn about things now is through Twitter, but
That's
it's
right.
happening. So there is a rumor, but not a formal confirmation.
There is a question regarding TDT services. Will TDT continue to be provided by QMHPs, or will they be provided by licensed and license eligible individuals when the enhancement occurs?
So this is a good question about enhancement in general that applies to another question we saw above about intensive in-home. And I would put voice to the comment typed by Laura Reed that any enhancements that are outside the current services that are in the proposal that was initially authorized, those are just ideas, not answers at this point. You will remember that Dr. Aplask, some of you, I know this is a much larger group than our kind of initial stakeholder work group with the associations and all of our agency partners, but on our public facing website, we have our original kind of continuum proposal, which is over 100 pages, I think, and goes through the evidence for different levels of care and a proposal for what services may look like. But any enhancements that would be done, for example, to therapeutic day treatment, to be for intensive in-home, those would go through stakeholder vetting, just as these services did that we have worked on with very closely with stakeholders over the last year. So particularly TDT, there would be significant overlap there with the Department of Education, with localities, with considering how TDT functions in our system, which touches more than just us as an agency. So there would be a considerable lift with that service, and that's why it was not included in kind of the initial priority, because we knew we would need a lot more time and a lot of people at the table to envision how that service might change. And likewise with intensive in-home, these services are not ones that are looking to be enhanced in the current proposal. And should they move into a phase where they were prioritized by the state and move forward, we would engage stakeholders in the same way in an intensive conversation about what those changes would look like to, again, enhance those services and think about how they could be improved in the future.
We do not have any unanswered enhancement questions at this time.
Great.
Oh, wait, there's one more. Sorry.
That's okay.
I understand, focused on the enhancements, but will PSR and mental health skill building continue to be valued and supported or funded as part of the overall options in the behavioral health system?
So I wish I had my slide that I could just pull up of our kind of very initial proposal of all of the different levels of care. Um, those different levels of care, were we able to pull that up, you would see that there are kind of some changes in conceptualization, for example, to mental health skill building, but that does not say that that level of care or type of service would be going away. It would mean that it would be enhanced. So it might be changed to bring in more evidence-based interventions into the service or change the way that the service is reimbursed. Because if you recall, I mean, one of the key aspects that stakeholders participated in the enhancement with bringing in these new services in phase one has been a rate study. So it's been, for example, for PACT, reestablishing the rate for PACT to assure that it was a fair compensation for delivering the service to fidelity. Oh, and look at this flexibility of our awesome team. Laura has just pulled up the original Continuum proposal. And so across the top on your screen, you can see all of the different levels of care from kind of a standardized perspective from a high functioning system. And within that, you can see that we also have a crosswalk slide, which kind of takes the names of our current services and crosswalks them so you see that they don't per se disappear, but kind of have different titles in a new system. I'm trying to see. So psychosocial rehabilitation, you will see, still exists here under the same name, but independent living and recovery resiliency services is kind of the new name for mental health skill building with a similar spirit. So it just means that we would be looking closely at how that service works, what different evidence-based principles can we bring into the service, how can we improve it, how can we assure that all of our rates are fair and allow for best practice within the services. I hope that answers your question, Paula. And again, this continuum that you see up on the screen, this was our kind of visioning, our big picture, because we knew that when we went into the initial, Dr. Plask and I, feels like, eons ago in the pre-COVID days, when we initially were conceptualizing this with our partners at the Farley Center, we knew that we needed to be able to describe to stakeholders and our agency and administration colleagues that we really have the big vision for what this would take. So what does the North Star look like? But that's not going to happen overnight with public funding and the time that it takes to implement this type of enhancement, that it would be a stepwise process where we would really need to follow the priorities of the needs of our members and the priorities for the state at the time and kind of take this chunk by chunk. And so this is kind of the big picture, high level overview. And then what we've been talking about today is really what got approved for an initial step in that direction. Are there any other questions that we haven't touched upon yet? Well, we want to thank you for your participation today. Again, we always welcome your questions, and you can send them to the enhanced BH email address. You can also see our website, our DMAS and DBHDS websites have materials related to the enhancement proposal and process on there. And we look forward to continued participation with you. Again, this is really just to give an update and let you know that the spirit is still alive, that our agencies are still committed, that we appreciate everyone's efforts that are going on in the system right now. And we just thank you for the service that you all are providing for our members. We thank you for your commitment during this really, really challenging and difficult time in our system, and look forward to moving forward together and improving the services that we can all offer together to improve people's lives. So thank you so much.
Yes, thank you. Take care, everyone.
Thank you, everybody.
Take care.